When I'm looking at a patient with intermediate risk kidney cancer, metastatic kidney cancer, again, I'm looking at a lot of their patient factors, individual factors. I'm looking at some tumor factors, and then of course we're looking at the data. And when I look at CABOSUN data, that points me towards using cabozantinib in a patient like we presented today. But suppose, for instance, that this patient had a different course. Suppose, for instance, he presented with his left kidney tumor that was resected with no lytic lesions. And it was 3 years later that the patient developed lung-only nodules. That patient would then be considered a good risk patient. And if those were largely asymptomatic, without laboratory values, abnormalities, we'd consider him a good risk patient. For me, that's a patient that still the standard of care is very reasonable to use sunitinib or pazopanib. Historically, for the last 10 years, that's been our standard of care, and many of these patients have done well with that. When we look at the CheckMate 214 data, the sunitinib control arm in the good risk patients really held up very, very well. Now, there are side effects that still need to be managed, and many of these patients can be on therapy for months or even years. So recognizing that, recognizing the importance of getting therapy that you can't just sort of make it through the next 4 weeks, but can make it through kind of cycle after cycle, sometimes requires some significant changes. So we'll use different regimens with a drug like sunitinib, a 2-1 regimen. With pazopanib, we may lower that down, and we may intermittently hold it on occasion. With cabozantinib, its label is broad. The reality is we're able to use a drug like that even in those settings. And there's evidence to suggest that in patients with good performance status, in patients without bone metastasis, in patients with low volume disease with cabozantinib, they all respond really well to cabozantinib, even better than sunitinib from the CABOSUN study. So even though we don't have direct evidence for using an agent like that in a good risk patient, you're not wrong to do that. So I look at this and I say, use the TKIs you're comfortable with, you're familiar with, recognize the signs and symptoms, work on helping these patients maintain a livable dose that they can maintain on. For good risk disease, we don't have to be at the MTD for most of these patients. And for many of these patients, we can actually even do deferred therapy. We don't talk about it. It's not necessarily something there's a lot of literature on, but we've done a large registry and we found that there's a number of practitioners who will defer systemic therapy in patients with good risk, low volume disease. And it sort of goes in line almost with intermittent therapy, starting out with an observation and then starting with therapy and then maybe holding it at some point for side effects and then restarting that. So these are approaches, again, we don't have a ton of data on this, but I can tell you in practices like mine and my colleagues around the country, we'll do these kind of things in order to maintain the best quality of life disease control balance. So looking at our case now, our 52-year-old gentleman who underwent nephrectomy with progression of disease, some bone metastases that were radiated and some lung nodules, it wouldn't be wrong at all if it's FDA approved in the near future to use a combination like nivolumab, ipilimumab. He's 52 years old, he's young, his tumor burden is not particularly high. This is the kind of patient that we might be able to achieve a complete response in. And we saw that in 9% of the patients in CheckMate 214. To me, that's a fantastic goal for many of our patients, something they're looking forward to, is to get the long-term disease control, whether that be a partial response or even complete response. So those would be the sort of rationale to starting with a strategy like that. In addition, that's a regimen that, although it's a little bit tough up front with a combination of 2 drugs, after 3 months, we're on what we'd consider to be kind of a maintenance therapy of just nivolumab alone. And that's really attractive. I think in the future, we're going to see opportunities to modify that dosing to every 4 weeks, or strategies that look at just more chronic dosing, for strategies for patients that could potentially be on therapy for potentially years. One of the questions I think we're going to struggle with in the field is, do they need to be on therapy that long? But before we answer those questions, I think the most important ones are, who are the patients that need to start on this therapy? How do we get them through that 3-month induction period to get to that problem? And when we get to a complete response or near PR, whether or not we can stop, those are good problems to have. I hope I struggle with that a lot in my practice. Right now, the big concern is making sure these patients can really optimize their outcomes with this regimen.